Say good afternoon to everybody. And welcome to this month's NAP webinar. And today we'll be having Dr. John Ejeh to present Radionuclide Therapy and Dosimetry in Nuclear Medicine. So I would like everybody to listen attentively as he presents. The PRO is going to read a brief biography of our presenter. So, Mr. Obina, please.
All right. Yeah, good afternoon, everybody. Welcome to August edition of the webinar of Nigerian Association of Medical Physicists. Before us here, we have Dr. John Ejeh, who is going to be our presenter today. Dr. Ejeh is a Deputy Director, Medical Physics, and can easily be described as the first nuclear medicine physicist in the country, as he was the pioneer physicist when the first department of nuclear medicine in the country was established in 2006 at the University College Hospital, Ibadan. He obtained his BSc Physics at the Benue State University, MSc Physics at the University of Ibadan, and PhD in Medical Physics, specializing in nuclear medicine physics at the University of Free State, Bloemfontein, South Africa. And is specializing in radionuclide dosimetry in targeted radionuclide therapy. That's all in nuclear medicine. He is well published and is passionate about the development of nuclear medicine in Nigeria. He's open to clinical and research collaborations. Dr. Ejeh is also an IAEA fellow and a radiation safety officer. That's the brief bio of Dr. John Ejeh. Dr. Ejeh, please, you can have the floor now. Share your screen while we go into the main business of the day. Thank you.
To the presentation again, and I will first of all start by saying a little thing about nuclear medicine in general, and then I will progress to radionuclide therapy. After that, I will go into dosimetry in nuclear medicine, and I will conclude. Nuclear medicine is the branch of science, of medicine, that makes use of ionizing radiation from unsealed radionuclides in the diagnosis and therapy of some diseases. In diagnosis, the aim is to make use of the information that is provided by the distribution of a pharmaceutical labeled with a radionuclide. Now, in nuclear medicine, what happens is that a drug that is that has affinity for the organ that we are interested in studying, or a body system that we are interested in studying, is attached with radionuclides and administered to the patient. And so the drug actually carries the radiation into the area of interest. And then how the radiopharmaceutical, that is a combination of the pharmaceutical and the radiation or the radionuclide, is distributed by the system. And that distribution can give us information about the physiological condition of that particular system or organ. And if it is in a tumor, for instance, it can give us information about the if it is in the tumor, it can give us the condition of that tumor, and then using that information, a diagnosis can be made. So it can be in the body system or organ, or the metabolic activity of the tumor within the body. And this the distribution of the radiopharmaceutical can then be imaged by an equipment, either a gamma camera that detects the gamma photons that are emanating from the patient, or a PET that is positron emission tomography machine can also acquire the image. And so one of the advantages of nuclear medicine image is that its usefulness goes down to the cellular level. Even sometimes it can be at the subcellular level. So it is possible that the diagnosis of a disease can be made at the earliest stage possible. And so because of this, nuclear medicine can thus provide a means of combining diagnostic and therapeutic procedures. And so this is an area of advantage of nuclear medicine, because unlike in radiology, where you have the focus being only on diagnosis, and in radiation oncology, you have the focus is on therapy. But in nuclear medicine, we can actually do the two. Only that for now, majority of nuclear medicine procedures are diagnostic in nature. So radionuclide therapy is, even though it has a very long history, but it is still much at the developmental stage. So in nuclear medicine therapy, we deal with the treatment of cancers of various kinds, non-malignant conditions, such as benign thyroid diseases, inflammatory joint diseases, and the palliation of bone pain due to metastasis. You know, when cancer has reached an advanced stage and it has metastasized into the skeletal system, radionuclide therapy can help in palliating the pain that the patients go through. In radionuclide therapy, radiopharmaceuticals that have affinity for tumor tissues are designed and administered to patients. So they accumulate and remain in these tumors for a period of time, irradiating the disease cells. You can, let me move this. So here we can see that tumors, cancer cells that overexpress the somatic receptors can attract radio-leveled peptides. So they bind together. Here is a peptide that is leveled with radionuclide, and then it binds with a receptor. You can see, binds with a receptor on the cancer cell, and then by binding to the receptor, it irradiates the cells at that point, and then that is how radionuclide therapy works. For example, iodine-131 has been very successful in terms of therapy, and it is because of the well-known sodium iodide importer protein target that that iodine has affinity for. And so that is why it has always been very, very successful. So radionuclides, okay, radionuclide therapy makes use of the targeting capability of labeled molecules to which the radionuclide is attached, and to selectively deliver cytotoxic levels of radiation to the disease site. So the ability of molecules that are labeled with radionuclides to target specific areas, especially specific disease cells, is what has made radionuclide therapy to be very, very successful. And like I said before, nuclear medicine radionuclide therapy has a very long history. But nuclear medicine, as it were, started with therapy as far back as the early 1900s, because the first known and recorded study that is carried out on humans is the one in 1927 by Blungard and Weiss. So we can now comfortably say that nuclear medicine actually started with radionuclide therapy, because the therapy in 1901 already radium had been used for treatment of skin lesion by placing radium in contact with the skin. And in 1936, phosphorus 32 was used to treat polycythemia vera. Then in 1942, iodine 131 was used for hyperthyroidism, and it was used for the treatment of thyroid cancer in 1944. So we can say that the use of radionuclides in therapy has existed for even more than 7 decades. And for a radionuclide to be a material for therapy, it must meet these 3 major criteria. And that is suitable nuclear medicine, nuclear decay characteristic. It should be easily produced and should have an amenable chemistry. So the requirements for such a radionuclide would be that, first of all, it should have a suitable half-life. So the half-life should be comparatively long, because if it is too short a half-life, then before the aim of using it is achieved, it would have decayed off. So we will end up not achieving anything. Therefore, it must have a comparatively long half-life. And again, for some logistics in the use of these radionuclides, if it has a comparatively long half-life, it will be possible for the transport of the radionuclide from the production site to wherever it is going to be used. So no matter how much it takes, it would have still be sufficient enough to reach where it is needed. And then it must also have energy that is high enough, or the energy actually determines the energy of the energy of the radiation produced by the radionuclide, we actually determine on what therapy it is going to be used for. And then another requirement is the availability of accompanying radiation, gamma radiation with particulate emitters. We know that the gamma radiation that accompanies the emission of other particles will not be too good for the patient in terms of radiation protection, because it will lead to an unnecessary irradiation of the patient and even other bystanders. So it is ordinarily taken that maybe it is not desirable. And then it also leads to the patient stay in the hospital, because the duration of stay in the hospital when patients receive these radionuclides is dependent on the radiation that is given off on the surface by the patient. And so if there is an accompanying gamma radiation, since the radiation can easily come out of the patient, it will be the determiner of how long the patient is going to stay in the hospital. So all these are the disadvantages of the accompanying gamma radiation. But on the other hand, with the gamma radiation, it is also possible to image the patient while the patient still has the therapeutic radionuclide inside him or her. And so with the accompanying gamma radiation, it is possible to monitor the effectiveness of the therapy. And again, another requirement is specific activity. The radionuclide must have a very high specific activity. For some therapeutic procedures, very low specific activity can be sufficient. But for peptide radionuclide therapy, and also for maybe antibody radionuclide therapy, if a low specific activity radionuclide is used, it is not going to be successful. So we need a high specific activity so that the small number of receptors that will be available will not be saturated if it is a low specific activity. So it is very, very important to look at the specific activity of the radionuclide before it can be used for any particular therapeutic procedure. Then the production logistic is another requirement, that the radionuclide to be used for therapy we should consider. Consider the logistics involved in the production. That is the radionuclide should be easily produced, and then just like I mentioned earlier, if the half-life is comparatively long, then it can be easy to transport this radionuclide from the site of production to where it is needed. For example, in Nigeria here, we don't have anywhere that we are producing medical radioactive materials. So they all have to be imported from abroad, from Europe and either from Europe or South Africa, for example. in Africa here. So because of the transport logistics and even post-production logistics, we need to have a radionuclide that is easily produced and can be transported easily. So these are the requirements for any radionuclide that will be used for therapy. So, and the desirable radionuclides for therapy are usually charged particle emitters. And this is due to their different effective penetration range in soft tissue, and then different linear energy transfer, and consequently, varied relative biological effectiveness. So for example, alpha particle with a range in tissue of about 100 micrometer tells you that alpha particles, when they are used for therapy, they cannot move beyond the immediate vicinity of where they are deposited. And so it is very, very good in terms of radiation burden to the patient, because if the alpha particle is restricted to only the target cells that are diseased, the surrounding cells will be spared. The surrounding healthy cells will be spared. And alpha particles, they have very high lengths. They can deposit high energies within a small space, especially at the cellular level. So that makes alpha particles the ideal particles that will be used for radionuclide therapy. They can deliver enough energy that can lead to irreparable double-strand break of the DNA strands of the cells. And so ordinarily, alpha particle emitters be the ideal candidate for radionuclide therapy. But unfortunately, not many of even the about 100 available ones are easily produced. So they have the problems of difficulty in production. And even the few ones that are clinically viable, their production also, they are not much of it is produced. So it is a very big problem with alpha emitters. Even as it is now, can only say that most of the alpha particle emitters are still at different stages of development. So most of them are still at different research levels. Some are trying to undergo clinical trials and all that. And so that makes beta particle emitters to be the most widely used in radionuclide therapy as it is now. Because Ejeh electrons produced from internal conversion or electron capture decay processes also have a range in tissue of about 10 micrometer. And so Ejeh electrons too cannot travel very far. In fact, some people are even suggesting that for one to be able to successfully use Ejeh electron emitters, they have to be deposited at the nucleus of the cells that is targeted for destruction. And for now, it is very, very difficult to produce such carriers that will take the Ejeh electrons to the nucleus of cells that have been targeted. So all these issues make it a bit difficult to use alpha emitters and Ejeh electron emitters in radionuclide therapy. So we now fall back on beta particles because beta particles have a range that is slightly above 1 millimeter. And then beta particles actually have a range, a spectrum of energies. So they can have energies from the minimum down to maximum energy. And because of that, beta particles provide a wide variety, a wide range of particles that can, a wide range of energies, a wide range of energies that can be used in therapy. And so it makes it a better candidate as it is now for radionuclide therapy. Then another requirement, especially for the type of particle to be used, is the nature of disease to be treated. So the choice of either to use an alpha emitter or a beta emitter would depend on the nature of the disease. For example, in terms of bone pain palliation, low energy betas are usually the candidate because with low energy beta emitters, it is sufficient to treat bone pain. And because of that, then some decisions have to be taken on what particle to be used in terms of the disease that is to be treated. And then the distribution of the target cells within the target volume also is a contributing factor in the choice of what particle to be used. Then the total volume of the tumor. Remember, alpha particles cannot travel very far. Like I mentioned before, the range of alpha particles in tissue is about 100 micrometer. And so if the tumor is a large one, then that may not be a candidate. And then actually alpha particles are better for small tumors. And so that also can determine the type of particle to be used. And the vascularity in the tumor, the more vascular the tumor is, the better for use of even beta particles, because that also helps, although a particular beta particle may not have enough energy to actually produce an irreparable damage to the DNA, but what is used here is what we call a crossfire effect, where you have several beta particles bombarding the cell at the same time. So the combined effect of the bombardment will be very, very successful than when it is only a very few beta particles. Then another determinant is the intramolecular distribution and pharmacokinetics of the tracer. So for this determinant, in the use of alpha particles and Ejeh electrons, it is a requirement that the distribution of the radiopharmaceutical has to be uniform. So if the distribution is uniform, then alpha particles and Ejeh electrons can be successful in the treatment. But beta particle doesn't have that requirement. With with a distribution that is not homogeneous, beta particles can still be successful. So all these are the determinants of which particle be used for a particular therapy. So here we have a table of the characteristics of important beta emitters which decay with accompanying gamma emission studied for radionuclide therapy. So these are some beta emitters that are clinically useful, that are being used in the clinic as of today. But the most successful of them all is the 131 and the lutetium 177. Lutetium 177 just came into the picture now, and it is developing in such a fast pace that it's even about taking over from the 131 in terms of the success in the use of this radionuclide or radionuclide therapy. So you can see that for the 131, the accompanying gamma energy, though we have about up to 3 types of major gamma emissions from iodine 131, but the major one is 364 keV, which has an abundance of 81.2%. So in terms of the radiation burden to the patient, it is actually very, very high. But again, because of the accompanying gamma rays, it is used for both diagnosis and therapy, and especially when it is used for therapy, it can also be used to actually look at the evaluation of how the therapy has been successful. And so it is a standard, even at our center here, that for every treatment, there must be a post-therapy scan, because this is like using one stone to kill 2 birds. You have given the radionuclide for therapy, and now you equally have the opportunity to use it for diagnosis or for treatment monitoring without actually giving the patient a further amount of radiopharmaceutical. So that is one of the advantages of having an accompanying gamma emission. And here is a list of some widely used or clinically established therapeutic radiopharmaceuticals. And if you look at this list, you will see that the number of diseases that can be treated with radionuclide is not so much, because most of these radionuclides, you can see they center around bone pain palliation, then neuroendocrine cancers, and then non-Hodgkin lymphoma, except for iodine-131 that is used for hyperthyroidism and thyroid carcinoma. And then iodine-131 is also being used for non-Hodgkin lymphoma and even neuroendocrine tumors. So we can say that for now, not many diseases can be treated with radionuclide. Now, in terms of treatment methods, in radionuclide therapy, we have one of the methods as empirical fixed dose. In the empirical fixed dose, which is adopted from chemotherapy, it is a situation whereby a particular amount of activity of radionuclide is given to every patient that comes for that particular disease. Or it is based on the weight of the patient per body surface area. An example is in the 131 therapy. For example, for a thyroid remnant ablation, that is after surgery to remove the thyroid cancer, then the remnant thyroid tissue, it is generally acceptable that about 3.7 gigabecquerel of iodine-131 be given to the patient about 4 weeks after surgery. And that is about 100 millicurie of iodine-131. So that is the standard. But if the cancer has reached an advanced stage where there are metastases, then it is allowed that up to about 7.4 gigabecquerel, that is about 200 millicurie of iodine-131 can be given to such a patient. And so it's like one size fits all in this case. So every patient that has thyroid cancer and that has undergone surgery, then is a candidate for 100 millicurie of iodine-131 for the remnant ablation of the thyroid tissue. Or you can just give 200 millicurie. So this is what is called empirical fixed dose method of therapy. Then for non-Hodgkin lymphoma and neuroendocrine tumors, what is used is what is called the adjusted activity regimen. And this is based on how many megabecquerel per body weight. And this is because of toxicity of the radiation toxicity to the healthy cells or tissues that the radiation may come across. So it is taken that a dose of 440 megabecquerel per kilogram, which is about 12 millicurie per kilogram, is considered as the maximum tolerated dose of iodine-131 MIBG. And so this is one of the methods that is used in radionuclide therapy. But this method actually has a lot of limitations And one of them is that at advanced stages, cancer cells can be radio-resistant. And so a situation whereby you say, okay, we just give, because this method is very simple, and the sources, the outcome is always very, very good. And then there is low failure rates when this method is used. And so because of that, practitioners are always comfortable going for the fixed dose. But if you are using the fixed dose, when the cells are radio resistant, then the treatment is no longer going to be effective. And so what needs to be done is maybe to increase the dose. And by what amount are you going to increase it now? Because that will become a problem, because one is not actually even assessing the radio resistance of the cell. Therefore, increasing this dose will have implications, because if the dose is too high, it will become dangerous to the patient and even to other healthy cells or tissues. And so because of that, this method is a disadvantaged method. Then this method also cannot account for the wide range of interpatient variability in the uptake and retention of activity. Because like I said earlier, it's like one size fits all. You use the same amount of dose to treat all patients. So it is a problem when the patients are not the same, because no two patients are the same in terms of how they take up the radioactivity, how the radioactivity distributes in them, how they retain it, and how they eliminate the radioactivity from the body. It's different from different patients. So it is not too correct to use just the same amount of radioactivity for every patient that presents with such a problem. Then there is also difficulty in evaluation of the risk and benefit of the various procedures. Then assessment of radiobiological effects of the therapy is absent when this fixed dose is used. And that brings us to the argument that dosimetry will be a better option in radionuclide therapy rather than the fixed dose regimen. So dosimetry in nuclear medicine or in radionuclide therapy is known as internal dosimetry, and it is the dosimetry of internally distributed radionuclides, which is aimed at the determination of the radiation energy deposited in different parts of the human body by internal radiation source. It is actually meant for the evaluation of the risks and benefits. You see, because in the fixed dose regimen, one of the problems is that evaluation of the risk and benefit of the use of the radiation in the treatment of these diseases is not there. So we need dosimetry to be able to have evaluation of the risk and benefit of the different procedures. And internal dosimetry has evolved from the technique of urine and blood measurements, where you take blood or blood samples or urine samples from the patients at different intervals, and then measure the amount of radioactivity. It has evolved down to image-based whole body dose determination. For now, the standard is to use an image of the patient to carry out dosimetry on that particular patient. And this is in response to some directives. The European Union has this directive, the Directive 43 of 1997, which specifically talked about for any medical exposure of individuals for radiotherapeutic purposes, the exposure has to be individually planned, and then it is reinforced in the directive of 2013. Here, it even went further to say that after planning individually, then the delivery must be verified. And so because of this, in Europe, because of that directive, it was later that from 2018, there is no any radionuclide therapy that can be done without those planning. So with this directive and this deadline that was given, it means the fixed dose regimen is going to be phased out in Europe. And when the therapy is planned based on the specific patient, what is known as a personalized medicine, this satisfies the need for the estimation of absorbed dose to the patient on an individual basis. So we now do the dosimetry of each individual patient, which is far, far, far better than the one that we have to use one amount of radiation dose for all patients. So dosimetry studies have demonstrated for both target and normal tissues that individual variation in uptake and retention coupled with individual variation in radiosensitivity leads to variable response that is seen in radionuclide therapy. And then because of advancement in technology, now we have we have SPECT and PET imaging, where we get SPECT images and PET images. And so when we do quantification on these images and coupled to patient-specific, like I mentioned before, doing a patient-specific dosimetry that is not based on models of the standard patient, standard man, standard standard male or standard female phantoms, will now give us what is personalized patient treatment according to the biokinetics of that particular individual. So radionuclide therapy is the only cancer treatment modality that allows imaging of the therapeutic drug in situ. And based on this, it is the duty of physicists to capitalize on this by providing the information necessary to enable optimal and cost-effective treatment. Unfortunately, I can say that I have only 3 more minutes left, and maybe we can do another. I can do another presentation on the dosimetry, because dosimetry is just starting, but there is no more time again. So maybe I can leave this for another time. I don't know, maybe let the organizers tell me about that. Thank you.
Yeah, thank you. Thank you, Dr. Ejeh. Concerning the dosimetry aspect, I think you should leave your email address so that if there's any question about the dosimetry aspects, they're going to send it to you, then you reply.
Okay.
So before I hand over to the General Secretary, Dr. Ejeh, I want to, while the lecture was going on, I noticed Professor Aweda, Professor Emi Aweda was joined the group. I don't think he's still on. And also we have Dr. Bidemi Akilade, and also I can see somebody joining from outside the country. The person, Mr. Babajide Falai, yes, is joining us from US. Is a customer relation officer for NAMP software, and then I think one of these days we're going to invite him to give one or two talk on this product. So right now we're going to go into the question and answer. So I would like to hand over to the General Secretary, Dr. Ejeh. Thank you.